Chapter 17, Evaluating Electronic Fetal Monitor Strips. Had a little issue there with trying to get my slides to go. So, all right, here we go. This is a fetal monitor strip, and the picture is taken from your book, Figure 17.6. The top portion shows the fetal heart rate, and the bottom portion shows the uterine contractions. Normal fetal heart rate is 110 to 160 beats per minute per your textbook. There are a few other sources that have slightly different numbers, but for testing purpose, we will follow your book of 110 to 160. Anything less than 110 is considered bradycardia, and anything over 160 is considered tachycardia. To determine the baseline, you look at a 10-minute period. When you look at the strip on the screen, we are looking at the top portion of the strip. Each little box is 10 seconds, and there are bold lines every 1 minute, so the strip on the screen is over a 12-minute period. You are determining what the average heart rate is measured over a clear 2 minutes in a 10-minute window. It's hard to read this one on the screen, so looking at this in your book will be easier. When determining the baseline, it has to be rounded to the nearest 5. For example, you can't say the baseline is 132. It has to be 130 or 135. You cannot accurately detect anything between the 5s. The baseline in this one is 135 beats per minute. Please don't get frustrated if you can't see that. We will practice more of these in class. I'm going to use the same strip to talk about variability. The term describes the fluctuation in the baseline fetal heart rate that causes the printed line to have an irregular wave-like appearance. This is one of the hardest terms for students and new nurses to understand. It is that fluctuation. So you're the labor nurse and you're in your patient's room. You're looking at the monitor, which will flash the fetal heart rate and put it on the paper. So you're watching the monitor and it reads 135. Then the next beat, it's 138, and then 132, and 135, 134, etc. This fluctuation is that variability. These are terms for how much variability we are noticing. First is absent variability. This is where there's no fluctuation. The fetal heart rate is consistently 135 and never changes. That shows us a flat line. What do we know about the heart and a flat line? It's not good. The baby is compromised and not tolerating labor at all. The next term is minimal variability. This is a fluctuation of 5 or less beats. Figure 17.7a shows that minimal variability. The baseline in that strip is 150, and you can see it barely veers away from 150. This baby could be sleeping, mom could have received some pain meds, or baby could be compromised as well. Your book lists other things that can affect the variability. As a nurse, we need that background info. Did we just give mom some pain meds? If so, we're anticipating this could happen. Changing the maternal position can sometimes help the variability to increase. Also, providing mom with something cold to drink and with some sugar, like juice, can wake up the fetus. Short spurts of minimal variability are good, but we don't want this to go on for the whole labor. Next is moderate variability. This is the fluctuation from 6 to 25 beats per minute and is a good thing. This shows that baby is tolerating labor well. Figure 17.7b shows moderate variability. You can tell with each beat that it's moving more. Remember, when you are assessing variability, you are looking over a clear 2-minute strip over 10 minutes. The last type of variability is called mark, and that is where it is over 25 beats per minute fluctuations. Your book doesn't have a picture of this, but I will see if I can find one to be able to bring it to class. Accelerations are a good thing, and another thing we want to note on our monitor strips. An acceleration indicates fetal well-being. Since we can't see inside the uterus to be sure baby is doing well, having accelerations present on the monitor strip is the next best thing. An acceleration is 15 beats above the baseline for at least 15 seconds. Remember 15 by 15, and they are good. This is figure 17.8 from your book. You first have to determine the baseline. In this strip, it's 135. So that means in order to be an acceleration, it has to be up to at least 150 beats per minute for at least 15 seconds. And both of those accelerations on the strip does that. When determining the 15 seconds, look at the opening of the acceleration. Remember, each of those small boxes are 10 seconds. We talked about the non-stress test, and one of the criteria for a reassuring non-stress test is to have 2 accelerations in a 20-minute window. It shows the fetus has adequate oxygenation. If the fetus is less than 32 weeks, you only need to have it increase from the baseline by 10 beats per minute, lasting 10 seconds. This is due to the fact that the CNS is not fully developed yet. Accelerations that last more than 10 minutes are considered to be a change in the baseline and not an acceleration. Accelerations are good, so the nursing interventions include just documenting. Decelerations are something we evaluate on the EFM. This time it will be a decrease from the baseline and may indicate baby is compromised. We'll talk about each of these individually. The 3 things you need to remember about decelerations are 1, are they good or bad? 2, what causes them? And 3, what are your nursing interventions? This is a picture of early deceleration. If we ask ourselves the 3 questions, 1, are they good or bad? They're good. 2, what causes them? Head compression is the cause. The fetal head is getting smushed a little bit with each contraction, and that is what is causing the deceleration. And 3, what do we need to do about it? Nothing but document. Since they are a good thing, they do not indicate any fetal compromise, so we just document our findings in the EMR. Now, to identify the early decelerations, you will notice on the monitor strip that you see a dip from the baseline. That is the deceleration. Early decelerations will mirror the contraction, and they are subtle drops from the baseline. The contractions are on the bottom portion of the monitor strip, so if you were to flip the early decels over, they would look just like the contractions. They basically start the deceleration process as a contraction starts, and once the contraction is done, so is the deceleration. The fetal heart rate is back to baseline. With each contraction, the head gets smushed as it's trying to move down the birth canal, and once the contraction is over, it's not getting smushed anymore. Remember, early decelerations are good. It's always good to be early, to class or to clinical. Late decelerations are a bad thing. It indicates uteroplacental insufficiency. This basically means that there's insufficient gas exchange that's occurring, so the fetus is not receiving what it needs. We're going to ask our 3 questions. 1, are they good or bad? Late decels are bad. What's causing it? Uteroplacental insufficiency, which is that poor gas exchange. And 3, what do we do about them? There are nursing interventions we must do. The first one is to change the maternal position. Left side is best, but if she's laying on her left, switch her to her right side. Sometimes just changing position will be enough to get the gas exchange going again. The next thing we do is if she is receiving oxytocin or pitocin during labor, we turn it off. Remember, oxytocin will cause contractions, and with each contraction, the fetus is already receiving less oxygenation due to the squeezing of the muscles, so we don't want her to keep contracting and cause more fetal compromise. The next thing we do is to give mom an IV fluid bolus. This extra fluid will help keep up the blood volume to help move blood volume to the placenta. You will also put oxygen on mom at 10 liters via face mask. You will contact the provider, and if these late decelerations continue, you will prepare for delivery. The way we identify late decelerations is that they typically start after the contraction has already started. Typically, it is after the nadir or the peak of the contraction before they start, and they do not return back to the baseline until after the contraction is over. If you look at the strip, you can see when the contraction is over. The fetal heart rate is still dipped down below the baseline. They usually do not dip below 40 beats per minute below that baseline. Remember, lates are bad. It's never good to be late to class or clinical. Variable decelerations are caused by cord compression. This can be the umbilical cord around the neck, body, a knot tied in the cord, or the fetus lying on the cord. You ask yourself the three questions. 1, are they good or bad? Bad. What causes them? Umbilical cord compression. And 3, what do we do about them? Your interventions are going to be close to the same as you would do for the late decelerations. You change the maternal position. If the fetus is lying on the cord, this can help alleviate that. They will sometimes put mom on her hands and knees as well. This once again will take the pressure off from the cord. Another position is they will have her get in the prone position, lean on her arms, and she elevates her hips and buttocks in the air. Having them higher will take the pressure off the cord as well. You would consider turning off the Pitocin if she is on it. It's not a definite to turn it off. You have to see if she's just having 1 or 2 variables, or are they all the time? Is there still good variability, and are there accelerations? If so, they may keep the oxytocin going. They can give an IV bolus of non-medicated fluids they have running. They will put oxygen on her at 10 liters via mask, and they will contact the provider. They may do a procedure called an amnioinfusion, which we'll talk about a little bit more in class. When looking at the EFM, variable D cells are either a V or W in shape. Remember, V for variable. They are abrupt down and abrupt back up. This is usually less than 30 seconds in duration. This can happen with a contraction or when they appear without regards to contractions.